is me, and I am the chair of primary care at the school. The school is located on Mare Island, just outside of Vallejo. It's a Vallejo address. And we've been there since 1997, our original school in San Francisco, and then moved to Mare Island, where we've kind of retrofitted into this military base. So there are a couple of different things that we're looking at. And one of the things that we really try to do is to look at the idealistic, up and coming, I want to fix everything type of a pre-medical student. And one of the reasons they get hardened is because that first 2 years is so much information, and it's just, you must be a student and you have to dedicate to all of this paperwork and the classroom and the book work. It's now online, but all of these, the coursework. The second 2 years is when we get to see patients. Basically, we're out there as a medical student, and those of you that have health degrees, you know, you're basically an apprentice, and it's walking around with the physician or the nurse practitioner or the PA or whoever it is that is your healthcare instructor, and seeing a patient and coming back and talking to that preceptor and making sure you're right. And then residency. So we're talking about a 7-year process of, you must always be right. You must know all of this information. You must get this ingrained. And oh, by the way, there's a human being you're trying to teach. So, or you're trying to treat. So how do we do it at Touro University of California? And we do it a couple of different ways. The first thing is to really look at the candidate. So what type of candidate do we want to be in our medical school class? And once we have 135 of those candidates, because that's our class size, what type of physician are we creating? So the candidate, we do have minimum qualifications, and they're not much different than any other medical school. So you, in order to apply, you have to have a 3.0 GPA from college. You have to have an MCAT score, so that's the medical pre-entrance exam. The score has to be about 500, and that's a 50 percentile. But a 503 is a 70th percentile, and a 510 is a 90th percentile. So the percentiles are, it's a very small range of scores. And if you meet that, we'll look through your application and we'll send you a secondary application. So now you're getting questions not from a medical school application service, but now you're getting it from the school itself. And the things we look at are, why Touro? Why do you want us? Why osteopathic medicine? Because we're a little different than an MD. And what type of things have you done in your life that prep you to become a caring physician? You've given us wonderful essays, you're given us wonderful scores, and you have great letters of recommendation that talk about how either altruistic you are, what type of leadership skills you have. We're now going to bring you in and interview you. And the candidate is interviewed with 4 other applicants. There are 3 people that interview, somebody on admissions committee, another faculty member, so 2 faculty members total, and a student. And the interviews happen and we ask questions, and we don't get a lot of time with the applicants. Pre-pandemic, they would come on campus, they would get a tour, they would meet the dean, they would have, you know, see the classrooms and everything like that. They would then meet with us in person for about an hour and a half. then have lunch with students where they could ask more questions, and then they go back home. Now we do everything on Zoom. So we actually have our first class, our freshman class, where 50% of them never saw the campus before their first lab, because their interviews were on Zoom. Everything was done that way. And so they didn't see the campus until we started, literally started classes. All right, after the interview. So I have now interviewed a student, the 5 students in front of me, and I take each one individually, and I am rating them on a scale from 1 to, a lot of it is yes and no, excuse me. A lot of it's yes and no. Can the candidate, do they understand osteopathic medicine? Are they interested in medicine versus other health careers? Can they undertake the physical rigors of the osteopathic education? Because this is, if you're not familiar with it, this is a lot of hands-on manipulative skills. So massage or chiropractic or other types of, again, hands-on skills that you need to be able to stand over your patient, and you need to have functioning hands. So can you do those rigors, or is it possible to accommodate? Because if it's impossible to accommodate, they won't be able to graduate, and that's not fair. Do you think that this person will do well academically? So again, we're looking at their grades, their scores, their letters of recommendation from college. But the one thing that we ask is, does this candidate think beyond themselves? Do they think outside themselves? So we're looking at, did they volunteer? Did they do more than just research? Did they, we've had some that have done AmeriCorps, for example. They've spent a year working in an underserved area as a gap year in between college and medical school. That gap year did not exist in when I was applying to medical school. You went straight from college right on in. More students now are taking that extra year to then give of themselves before they have to internalize and be a little bit more selfish with their education. And again, we're rating, and then we rate the candidate. Will you reject to accept, all the way from a 0 to a 6, and it's every 0.25. So it'll go, 1, 1.25, 1.5, 1.75, 2.0, and we bring it all the way up. We then take those 3 scores and average them, and that gives the admissions committee the information. During the interview, this person scored a 5.2, that person scored a 6.0, that person scored a 2.3. Now we discuss them. And so what are we really looking for when we sit down and discuss them at admissions committee? All of the committee members meet. Any of the faculty is invited as well. And we have student representatives as well. And we're going over, if everybody agreed to admit, there's not a lot to have to discuss, but these people that kind of are like, well, I don't know, on the fence, or there's a discrepancy because 2 people rated them a 6, let's take them, and 1 person rated this person a 1, let's reject. We need to sit and talk. And again, we're looking at someone that doesn't necessarily have to absolutely understand or believe in the osteopathic philosophy. The osteopathic philosophy of medicine is that the body has an inherent ability to heal itself. So if you are able to get blood and lymphatic fluid and into areas of disease, then the body can heal itself faster. There's an integration between the musculoskeletal and nervous systems, and you take into account the patient's mind, body, and spirit. So it goes beyond just this diseased organ. So can we get someone as a candidate that understands that concept or that is willing to learn that concept? Because that's very important. Do we think that this person will pass academically? We really don't want to take somebody at the expense of medical school that won't be able to meet minimum competency to take care of people when it's $59,000 a year. And so we really take that into account as well. So we don't want to stress our students out with the expense if we don't think they're going to be able to overall handle the rigors of the curriculum. We don't want to, we already know it's stressful. We don't want to even add more stress to somebody and then again, burn them out so that empathy is gone. Okay. So now we've got our class of 135. So what do we do in those first 2 years that helps to maintain that idealism that 10-year-old has when they say, I want to grow up and be a doctor? Or the high schooler that discovered that they can, help people and it doesn't gross them out and they're not, somebody's bleeding, I know what to do. Or the chemical engineer that discovered that they'd rather do more with people than with their research. So some of the things that we offer, in addition to everybody needs to know anatomy and physiology and biochemistry and all those other things, we have a series of ethics lectures where over the first 2 years, where we are teaching foundational stuff during year 1, the understanding of the physician-patient contract and the Latin that they're going to need to be able to pass their competency exams or their board exams to get a license. So simple foundational things all the way to they are the ethics committee of a hospital and we are dealing with this case. And there's no right or wrong. The students just have to discuss with each other. We have very specific labs that Dr. Schultz may have been involved in, which is the difficult patient encounter. We have actors, community volunteers that are given a script and they walk into a room with several students and they're either angry or drunk or whatever. And they're coming on to the student. They're very flirtatious. And it's these different scenarios so that a student will not flip out when the first time they see this in real life, because it happens in real life. But they're in a controlled environment. They know they've got a lot of support. They're able to have a debriefing with the standardized patient. But that's an uncomfortable lab for a lot of students. We have similarly a delivering bad news lab where we have the standardized patients come in and we've got a military wife that comes back from her deployment to a husband to find out that she's got gonorrhea. She's been gone for 3 years. We've got older woman, an octogenarian, whose son is taking her medication and selling it. We have, and again, these are difficult encounters. And so we have a student that's interviewing the standardized patient as a patient. And has to deal with this. And then we do a debriefing. What was uncomfortable and what worked well. And we really want the students to understand what's going on. We do let the students know that some of the things that we do may cause some angst when we deal with, for example, our child abuse or our substance use disorders, things like that, that may depending on the history of the student, may spark some bad memories or may cause some angst. And so we give a warning with each of our courses, and medical schools in California do that, but not all over the country. We have Project Prepare. Project Prepare are professional folks that come in and run cases that are LGBTQI or kind of fall along those difficult patient encounters. And the patient themselves are the trained instructors. And so they are the patient, and then they do the debrief. And that's been very successful. And this past year, we introduced structural competency into our curriculum. And so we run a course on structural competency, which includes social determinants of health. So going again, mind, body, spirit, what else could be causing the issue? Why is John not getting better and I've been taking care of him for 3 years? Could it be that he can't afford his medication, or that he doesn't have transportation to come to me, or he's on federal food? And so, and this actually happened to me. I had a diabetic that I could not control. And after 2 years of taking care of this gentleman, I said, what are you eating? What is your diet? What's going on? And the answer he gave me, and I can't believe it took me this long to get there, was I get bread, cheese, and peanut butter from the government. That's my food. Ugh. And if I had known to ask several years earlier, I could have had this man on a diet of bread, cheese, and peanut butter with a multiple vitamin to control his insulin-dependent diabetes. I should know better. So my students know better because of what I went through as well. So that's part of the structural competency. What else is going on that interplays? We just had a practical exam today. Our first year students were all given a patient, one of the standardized patient actors, and their complaint was fatigue. All right. And I'm sitting in the room with my little gentleman whose fatigue is because of pneumonia, and the student is doing their thing. And part of what we grade on is empathy. If I tell you, well, I'm tired, and the reason I'm tired is, maybe it has something to do with the fact that my grandmother is in the ICU with COVID, and my husband just asked me for a divorce, and my 2 kids are fighting all the time, and whatever. I expect my student to stop writing their notes and look at that patient and say, what can I do? And they are all taught that that is an expectation. So during the practical exams, there are several different points where we expect the student, and it's usually not that, gross of an issue, but where we expect the student to stop, look up at their patient and direct that, I'm sorry to hear that. And here's what we're going to do to work together to make it better. And they're graded on that. Before the pandemic, we had what was called early clinical exposure or early clinical experiences, where our students would go into physician offices and then shadow. And so they were exposed to different medical conditions, and they could then sit down and we would discuss with them what they had seen and what they good and bad that they had seen with the doctors they were with. And we are still able to do what's called clinical integration. So during the substance use and pain module, we have someone that comes in with, and this is me, I do this with my daughter, who's a 15-year now recovered meth addict who graduated law school, and we're saying, this is the face of addiction. This is what it looks like. It's not that stereotypical whatever. When we have neuromuscular, they bring in someone that's got muscular dystrophy or myasthenia, or, so the students are getting exposed to actual patients, actual people that come in to deal with something that relates back to their curriculum. So they're seeing that. And then we have OSCEs, and OSCEs are called Objective Structured Clinical Exams. So at the end of 2 years, you get an OSCE. You're going to see 4 patients. It's going to be recorded. You're going to do your thing. It is timed. So we expect you to do a very focused physical and a focused history, include the empathy, write a note. They've got somewhere around 20 minutes to do that for 4 patients. And then we all sit down. I have usually 4 students in my room, and we watch the videos and we talk peer to peer. The students are comparing to each other. What was done well? What could have been done better? And so they're recognizing it, not just in their classmate, but in themselves. What could I have done better? So that's important. In the second 2 years, when they're in the clinic, we have their OSCE again, and we have what we call e-conferences. So once a month or twice a month, depending on the rotation they're on, all of the family medicine students come together and present the case. All of the internists, internal medicine students come together, present a case. Surgery, OB, ER, we have the students all come together on Zoom, and they have to present a patient that they've been seeing and walk through it in front of their peers and at least 2 faculty. And we question them all the time. What ethical dilemmas did you have? What did you have to go through? What else is going on? And so they're getting it during years 3 and 4 as well. Callbacks, we bring third-year students back to campus where they are seeing patients and they're learning some more skills, and we don't want them to forget that we expect them to be empathetic, because now we've seen that burnout that Dr. Schultz talked about in that first 2 years. We see now they're out in, I know what I taught you, but now you're going out there and you're going out there with docs that don't do it quite as detailed as we taught you. So let's remind you what the ideal is, go back to the ideal. And then we have the preceptor evaluations, and that's part of the evaluation of the doctor that is hosting the student, is how well do they care about the student? How well were they able to get patient rapport? How did they treat the office staff? That's important too. It's not just me and my patient. It's everybody else that helps to make that patient's encounter much better for the patient. It's all about the patient, right? Okay. So what else do we do? Well, we do have a bioethics club, and the club has been very successful. We've had a national tournament now for 2 years, where we are discussing these difficult cases and what would you do? And it is done in pure debate style. So pro, con talks about con talks about pro, and then we judge it. And that's a little bit more formal than this education, but what we're seeing is that the students that tend to participate tend to be the more empathetic, and also the brighter students in the class. And it's because they tend to care, so they really put their heart and soul into what it is they're learning. We do have a free clinic in Vallejo, and where we added what we call Project Hope. Project Hope takes a patient. They're not called patients with them, they're called clients. And they ask those structural competency and social determinant questions. We start with, how do you define health, client? What will get you to that health, client? And we've been able to match folks up with food banks. We actually, our biggest success was this one gentleman that was unemployed and homeless, living in his car. And within 4 months, we were able to find him a job, get him clothing, get him an apartment, and he's on his own for the first time in months. And it's just because we've been able to hook him up with the resources that he didn't know existed, but that's our job. So that's Project Hope, and it's been very successful, and it works throughout the College of Medicine, Nursing, Pharmacy, and our PA program. The IDEA Committee, which I don't have the acronym, I don't remember what it stands for. But it's inclusivity, diversity, something and something. Where again, this is a student-led committee that does have a faculty member that is their, I'm blanking on a word, but is their promoter, or the person that their lead facilitator. And they go through anonymous or not concerns that the class may have. When coronavirus first came out, and our population at the medical school is primarily Asian Indian and then Asian, and the Asian based students, so whether it be Chinese, Japanese, Korean, Filipino, were being harassed in Vallejo because they brought COVID, right? The IDEA Committee jumped on that and started doing educational pieces in the community, started helping the students to deal with everything that was going on with that type of ignorance and bias that was going on with them. We do have our students on major committees throughout the comms so that the students do have input into their curriculum. The admissions, like I said, there are a couple of other committees that they are part of or can create if there is a need, and there are some committees that are institutional, so they are nursing and the PAs and things, and there are some that are just separate comm. And thank you very much, Arun. Yes. Inclusion, diversity, equity, and accessibility. It's absolutely, that's actually, thank you, that is it. But anyway, the student vote is equivalent to any faculty vote on these committees. And so the students have been able to feel that we care as faculty for them. And it makes it easier to then care about your peer, because we're not competing with each other like used to be, probably when Harley and I went to school. If you couldn't pass a nat in my class, if you didn't know what it was in anatomy, they would rip it out. So I don't know what that muscle is. So somebody would come in and take a scalpel and remove that muscle. So it wasn't asked on the test. We're not doing that anymore. You know, we're not trying to sabotage somebody else so that I get the residency spot and they don't. This is a group of students that all holds each other's hands and tries to pull each other up, all 135 of them. And so they need to see that we are the examples. So we are their mentors. Each student is assigned a faculty mentor, and that's part of what we do as well. We try to identify very early students at risk, whether it be mental health, academics, professionalism. We are really trying to identify the student at risk and get them to the counselors, the professionalism committee. We have several different student peers that are fellows, so they're actually staying a fifth year, who tutor. We have others that are tutors through work study programs. So again, if we can identify early, we have a better success rate of keeping somebody in, not having them burn out. And then there are some empathy projects on campus, and I will show those in a second. So yeah, come on, you know you can work. There we go. So we do have some data as well. We tell the student, the first thing we tell the student is that they are creating their own letter of recommendation from the dean, which is the MSPE, Medical Student Performance Evaluation. And it basically, it comes from every medical school and goes into the residency, I'm going to apply for it data bank that says, all right, Gail Feinberg came into the school, matriculated on this date, will graduate on this date, and has either done well, not done so well, really shouldn't be here. You know, and it's kind of a score, and it's very, very templated so that they're talking about clubs and organizations and leadership and academics and what else did I do? And we give our students the ability to create their own elective, which goes into this letter as well. But we're telling the students, we look at all of this because you're writing this letter. Your behavior, your caring for someone else, honestly caring, not acting it out, your academics, how you behave, not just professionally on campus, but when you're in a hospital or when you're the guest in someone's office, all goes into this. And so we tell them that. We know we've been successful because I'll show you hard data, but we are also getting hospitals that are calling us saying, I've had students from, and they list the schools, and we're asking your students to come back. We don't want them. So our students are doing something right. This is the hospital request for our students. We have not looked at any data there, but I can tell you that over the past 4 years, I've been working for 7 now, over the past 4 years, we've been able to get our students into more hospitals because word of mouth is going from hospital A to hospital B in the same town, that these students work and they show up when they're supposed to and they stay late and they really care and they do the research and they're great with patients and they handle my office staff really well and they do whatever. And so we're getting hospitals that just say, all right, we're not going to have UC Davis or Cal North State, or we want your students to come, which is really, really nice. So this is our data, and this is from the class of 2021 and the class that's about to graduate. We know that the more empathetic and sympathetic type of personality, like Dr. Schultz has said, the more they're going into primary care specialties. So we're looking at family, internal medicine, pediatrics, and then you can add OBGYN, geriatrics, and psychiatry. Now, those last 3, geriatrics is a subspecialty of either family medicine or internal. Psychiatry is not really thought of as primary care. How can you be a psychiatrist and not be empathetic? And OB-GYN, which for a while was considered primary care. It's not anymore. It's a surgical specialty. But again, because of the type of work that they're doing, is still, for some data, considered primary care. So in 2021, we had 60% of our class, so family, internal, and pediatrics. And in 2022, we had 59%, so primary care, internal medicine, pediatrics of our class. And then you add the psychiatry and the OB, which is a little bit sliver over here. And in both years, we are approaching close to 75% of our class that goes into primary care specialties or specialties that are known for empathy and sympathy. And we are staying primarily in California. The data that I'm really happy about is that we are in the top 15 nationally over the past 10 years. Last year, we were number 12 for graduates matching into primary care residencies. And now that's truly considered internal medicine, family medicine, pediatrics, OB. That's what they're talking about. We are and have been for several years the #1 medical school in California for having primary care physicians coming back or staying in the state and working with disadvantaged and rural populations. And this says 55% of the class, but the last 2 years was 60%. And then we have a couple of grants that we have started also, where we're actually studying empathy in our training and with our patients as well. So the green one here is a student study. The, I don't know, kind of bluish one here is a patient experience. Okay, so that's what we're doing. The data shows we're doing what we're supposed to be doing. I mean, our mission is to train physicians that want to go into primary care and work in underserved areas. That is the mission of most osteopathic schools, because when osteopathic medicine started a little bit after the Civil War, that's what was trained. We're family docs. And so traditionally, we still put out more primary care physicians. There are 44 schools now. There were 12 when I went to school, but there are 44 osteopathic schools. About 27 to 30% of all medical graduates are osteopathic students. And we think at Touro that we're doing it well. So I'm happy to answer any questions anybody may have as well. And